Good, good afternoon, everyone. Welcome to this SOM webinar, Basics in Occupational Health. This afternoon's webinar is on noise issues at work. And we're fortunate enough to have Clare Forshaw, who will be presenting this afternoon. My name is Ian Lawson. I will be chairing the session, so I'm just really just taking questions, which you can put into the chat box. Try and make them as succinct as possible, please, because I imagine we'll get quite a lot of questions, and some maybe repeat themselves, but we'll have to see how we get to at the end. Right. So Clare Forshaw, you've seen her bio on the website there. She's Principal Strategy Implementation Manager, the Rail Safety and Standards Board, and other titles as well. I think rather than eat into Clare's time, I'll just draw attention to what I think is noteworthy in her bio is that she's been the real sort of force behind setting up of the UK Hearing Conservation Association, which was launched in 2019. And I know from the fact that Clare chairs the special interest group on noise induced hearing loss, that she is very passionate about this topic. So I'm looking forward to the presentation, and I'll hand over to Clare.
Thanks, Ian, and good afternoon, everybody. Thanks for joining us today. It's great to see a large number of people signing in, and I'm sure might catch up with this at a later date as well. And it gives me encouragement that the topic of noise and hearing health is really taking kind of pride of place in people's ambitions. So that's great to see. So thank you for your attention and interest. I believe the context of the talk today is to provide a kind of broader view of noise at work. So I think I'll go through introducing some of the challenges that we face around improving the profile and addressing this topic in a kind of modern society, in a modern workplace. Some of the barriers that we have to progress, the crucial role of health surveillance in all of this, and really what the future of health surveillance might look like. So I'm hoping that is some of the stuff I might talk to you about today. So first of all, I mean, I'll say I'm encouraged by the numbers interested in attending, not just this webinar, but other kind of sessions on noise and hearing health. Because I think for a lot of people, the question is really, well, you know, is it still a problem? There was a recent Workplace Health Expert Committee report published, the work for HSE in undertaking various roles of advice and research for HSE in health topics. And they published a report, which I can circulate if people haven't seen it, on the prevalence of noise exposure and noise-induced hearing loss in kind of the current world of work. And they kind of suggested, well, I think a lot of people feel that, well, heavy industries reduced, you know, surely we've not got as much exposure to high levels of noise as we used to have in the past. And therefore we can kind of resign noise-induced hearing loss to the past as well. But the problem is, you know, we've got a lot of different industries, and I think I might allude later on to the fact that, you know, not just through the profile of listening habits, but, you know, different industries, leisure industries, where we have listening at work, not just high noise exposure. So people use headphones at work, both for personal listening, but also listening to content for work. And there's a real kind of blurred area around, you know, duties and liabilities around that kind of area. But that would be possibly another topic to explore. But, you know, for me, noise continues to be a problem. Hearing continues to be a problem. And with that, I'd just show you the top 10 diseases, occupational diseases, where successful claims are processed by the Compensation Recovery Unit at DWP. And obviously we'll see, you know, some very common occupational diseases there, which we'd expect to see. And those of you who are very acute at maybe adding that up, you will see there's only 9 diseases actually on that slide, because by far and above the biggest occupational disease for which successful claims are made are around occupational deafness. So we continue to see that being the kind of biggest area of claims, and obviously one of the biggest industrial diseases that we have to deal with. I also think there's a kind of change and a shift in our approach to hearing health in terms of the regulations and what we do. In occupational health, we spend a majority of our time looking for noise-induced hearing loss, forgetting the kind of other hearing health and health implications of noise exposure. We don't really tend to try to quantify or diagnose or capture, in my opinion, enough issues around tinnitus, which we know is closely linked to noise-induced hearing loss and closely linked to noise exposure, specifically in particular industries such as the music and entertainment sector, but also industries with high impact or impulsive noises. So I think it would be interesting in the future to make sure we start to look at actually what is the prevalence of tinnitus. We don't really have a handle on that and the scale of that. I think it's becoming more appreciated and understood, particularly because we spend a lot more time now thinking about well-being and mental health, that noise is a stressor. It increases our blood pressure, it affects our sleep, and therefore it has been reported in various studies the implications that has on cardiovascular risk. And one study quoted that every 5 decibel increase in an average 24-hour noise level was associated with a 34% increase in heart attacks, strokes, and other serious heart-related problems. Now, obviously, these are kind of due to environmental noise pollution, these kind of studies, but we can only, just imagine how that transfers to noisy workplaces as well. So something, there around that kind of well-being link between noise exposure and people's general health. And I think one of the most kind of significant findings recently, which has really drawn attention to noise-induced hearing loss, is the link that's been made to cognitive decline and dementia. And there's some statistics on there which I think are quite shocking, concerning, and as I say, certainly highlights ever more the need to address noise-induced hearing loss, because a lot of these reports have found that noise-induced hearing loss is what they call the biggest modifiable factor related to risk of dementia in later life. So the one thing we can affect in terms of prevention and the link to dementia would be to prevent hearing loss, as I say, one of the greatest modifiable factor. We're not sure of the direct kind of causal link, but I always kind of use the analogy of you think of like the kind of grumpy old granddad sat in the corner, who's isolated from the family, can't hear properly, and therefore withdraws from social connection. And we probably, maybe from studies over COVID, can only start to make those kind of links of how that social isolation can contribute to further cognitive decline in that area. And as I kind of mentioned before, the regulations, the action levels, the risk threshold data that's used within the guidance to the regulations in the UK or in Great Britain are based on kind of population data 50 years old. And I think we're all probably aware that the profile of noise exposure, social noise exposure, is changing. You only have to walk down the street, get on a bus, visit a local cafe. Most people are plugged into some kind of content for a much longer proportion of the day, whether that's music, podcasts, gaming. So the whole life exposure to noise is changing. And that has obvious, I think, implications for workplace management. And I don't think we've quite made that connection yet. I know there's a lot of anecdotal evidence, but also evidence from the States. I don't think we've got great evidence in the UK, but that people, I mean, validated evidence. There's a lot of anecdotal evidence that young people coming into our workplaces are already suffering some high levels of noise-induced hearing loss. Now we have to manage this risk. We have to protect what's left, and obviously that exposure is going to continue through their life. So if they're already suffering at 18, 20, 25 years of age from sound-induced hearing loss, that's going to make them more susceptible. And as I say, allowing an 85 dB 8-hour average exposure may not any longer be suitable or sufficient to really protect hearing for the long term. And to just give you an idea of what that might look like, if somebody's listening to their headphones on the way to work for an hour on the tube or on the bus or whatever, about 94, which isn't that high when you think about what normal listening levels are, they will have had their daily exposure within that hour at 94 dB. And the other equivalent is if they've been in a nightclub for a weekend. And we have to be very careful around education, around listening habits, because we don't want to say, stop listening to music, stop enjoying content. But I think there is an awareness role to play around, well, how much do you listen outside of work? And as I alluded to before, sometimes people are listening in work and they might either have their ear pods under their muffs, their protecting muffs, or they might be wearing, I think we had a question last week at a conference about somebody had asked, could they use their noise cancelling headphones as hearing protection, which from me, I gave a resounding no. But, some of the modern challenges and issues around noise and hearing. So, as I say, it's great to see so many people interested. And if you weren't aware, I thought I'd highlight the fact that the HSE, that's the regulator of health and safety in Great Britain, are now currently out there implementing their inspection programme focused on workplace noise. Now, it's over 30 years since they last did an inspection campaign and focused on noise. And the only reason they did that 30 years ago was because we had the new directive, and they really wanted to be shown to be doing something about implementing new regulations under that European directive on noise. A brief introduction to what that is, so you know what it is. They are going to be focusing on hearing protection management initially, and we can talk a little bit more later on about how you, as occupational health professionals, might be supporting your duty holders in that area. And that has been criticised because obviously hearing protection is the bottom of the hierarchy. But again, I think we'll all agree that for the majority of workplaces, the focus of control tends to be in the provision of hearing protection. The inspectors are going to present at our UK Hearing Conservation Association conference in November this year. If anybody's interested in coming and finding sort of first-hand, hot off the press, their findings, we'll be hearing presentations of that conference. Then they're going to move on to looking at control measures and the effectiveness of control measures through the programme. And then there's kind of a suggestion, a plan that they will start to look at health surveillance and how good and adequate health surveillance is. So I think it's given us a bit of time to get our ducks in a row and make sure we're delivering a robust health surveillance. And then the plan is for them to go back and look at hearing protection again. So quite interesting that they're spending, not just a quick fix look at this issue, that they're rolling out a programme over a number of years. So shows how seriously the regulator is taking this subject now. So I've already done a plug. Apologies if I've upset anybody by the random plug stuck in there, but this is our conference, the UKHC conference, which we were running in November later this year. So as I say, I was asked to sort of give a kind of rounded view of noise at work. So I thought I would just outline what hearing conservation is, what a good hearing conservation programme looks like, and how we need a more integrated approach to, or more holistic approach to managing hearing health and reducing noise. We've got, as I've just mentioned, a real problem that it's a kind of race to the bottom for noise, and it has been for a long time, that we just heavily focus on personal protective equipment when we know that is the least effective and the last line of defence in this area. So there's a real challenge about education and upskilling and providing knowledge about what the hierarchy of control looks like for noise, which I'll show you in a second. The critical role that health surveillance plays in that. So if we are relying on hearing protection, that all of those people will be under health surveillance for noise, or they should be, because it's known to fail. So how effective is our health surveillance program in feeding back that information and the results related to hearing protection use and where exposures are actually happening? Should we be looking more broadly about education around sound exposure and leisure exposure to make sure we're really protecting people and preventing that hearing health harm? And that using that kind of opportunity around people's interest about the kind of wellbeing agenda and the kind of multi-factorial implications that noise and hearing health can have. So we've got a number of resources at the UK Hearing Conservation Association. One thing we did develop was the hierarchy, or an example hierarchy of control for noise. You can download this from our website, but it just goes through, as I say, what the hierarchy is, what it might look like for noise, some examples in there. We certainly need to get as many examples and hopefully work with the HSE as we continue to do to push people to that kind of top level of stopping the noise, turning the noise down, moving away from the noise, some simple messages, and hopefully some of this can help you in your role in supporting the employer with the outcomes of health surveillance, to say these are some of the things you could do better or you could look at to improve exposure, which is the critical thing if we're going to prevent harm and to reduce exposure. So moving on to the role of health surveillance in all of this and where this can help, and a bit of a kind of revisit guide. Apologies for all those who have heard all this before, but health surveillance is not a kind of nice to have health check. This is a legal requirement. It is part of the risk management process. Going back to that kind of inspection programme from the HSE, the onus is on the duty holder to have the right health surveillance and have access to the right health surveillance and to act on health surveillance results. A lot of you may be in-house providers who are part of that duty, or external consultants who come in and support the duty holder in meeting their obligation in law here. So as I said, all those relying on hearing protection should be under health surveillance, because we know that is going to possibly fail to harmful noise levels. All health surveillance, this is a general message about health surveillance, not just for noise. All health surveillance needs to have a robust technique to be able to diagnose or to be able to pick up the health effect, should allow early identification of disease so people can act on the results in a timely manner to reduce exposure. We also know that it can identify vulnerable or susceptible workers, so we need to maybe think sometimes below the legal action values in terms of who those workers might be. And when we identify other medical health related issues, we need a process to be able to refer those people on for further support for their individual health needs or concerns, or to specialists, which I'll pick up on again later. So it's risk-based. It can only add value where we know what people are exposed to. So we need to identify those who are at risk of noise-induced hearing loss. So that's harm caused by noise in the workplace. And also understand that kind of similarly exposed groups. So we can say these groups of workers in this area or in this role have a similar exposure. Therefore, we can help the employer by feeding back grouped anonymised data on the results of health surveillance for that group of workers, so the employer can understand the picture of what's happening and where to focus their efforts in improving controls and reducing exposure. So it is that kind of final check, and there are other things like exposure monitoring or safety checks and audits on controls, but ultimately where that kind of quality control in the workplace is not working, health surveillance is the final net to sort of catch, well, what is actually happening to people's health? What are we missing? So it is part of that risk assessment process, and we need to remember that whatever we feed back, whatever information we glean from this process is useful in advising that risk management approach. I've always thought that, you know, alongside that kind of critical role in risk assessment and risk management, health surveillance is one of the best opportunities to educate and engage. It's a real chance to get individuals on a one-to-one basis to say, coach them, to say educate them, improve their attitudes. So we can't forget that kind of role. And in that, I wanted to sort of again point to some of the resources that we have from the HCA, because I know a lot of you will spend time coaching and advising individuals on use of their hearing protection. So the poster on the left is a fit check-in poster. So you can say to people, well, if you put your hearing protection in every day, do you know how to make sure you've fit it properly, and that it is actually providing that seal that it's expected to in terms of providing the protection that it says on the box. So there's a poster there, and the other guidance document is about fit testing, and this is something, again, possibly in the future we might see more health surveillance appointments, occupational health appointments, integrating fit testing. So if any of you do any respiratory health surveillance, you will probably be familiar with fit testing for respiratory protection, which is now a kind of part of the legal duty that you have to, if you're relying on close fitting respirators, you have to be fitted to that respirator as an individual. There is a number of techniques now which allow fit testing for hearing protectors. All our ear canals are different, as I'm sure you know. All hearing protection devices are different, and we need to test people and check, if you're relying on these devices, do they fit you? Can you achieve a fit? And do you understand how to achieve a fit? And can we test that independently to say, yes, you did achieve a fit with this hearing protector, you understand how to fit it, go away and use it, and use the fit check-in approach to make sure you continue to keep that protected. So, as I say, some resources available out there, and an opportunity maybe through health surveillance appointments to provide better coaching and influence where we still have heavy reliance on the use of hearing protection devices. So noise health surveillance, by law in Great Britain, is required at or above 85 decibels. That's the 8-hour average dose over a working day. The regulations do kind of qualify that with a regular and frequent exposure, because I know in the past people were saying things like, well, we walk through a noisy area for 2 minutes once a week. That wouldn't on its own require health surveillance, but where there's regular exposure, this is pretty much happening on a regular basis, we would expect health surveillance in those circumstances. It's the process of noise health surveillance is to conduct a noise and health questionnaire initially, followed by an audiometric test, and the guidance for that is laid out in L108. Again, we need to remember that in order for this test to be a repeatable and robust test, there are specific requirements, both in terms of calibration of equipment and management of the equipment, but also in providing a soundproof environment. And there's an EN standard available which details the background noise levels in these environments. I only mention it because this has a huge influence on the outcome of the audiometric results, and quite often in busy workplaces, it's not always achieved that we get a sufficient soundproof environment conduct these tests. So it's really sort of, you know, how reliable are our results if we're not achieving that. People need to be instructed on how to do the test, because it does rely on the individual to respond. We don't want them cheating either way to sort of say they want to pass or they want to fail the test. So it does rely on the individual's engagement and compliance. And again, just to note that it does, I'd say you probably all understand this, but just to remember that it does test because it tests the ability to hear pure tones, does what it says on the tin. It tests the complete auditory pathway, so it doesn't distinguish exactly where those hearing response issues might be happening. So I'm sure many of you on the call are already aware that there have been a number of challenges around noise health surveillance, and predominantly the biggest issue that we have, notwithstanding the practical issues we're dealing with at the moment, but fundamentally the challenge has been that noise health surveillance has not been picking up cases of noise-induced hearing loss. And I know there's a criticism of the HSE categorisation scheme in that area, and I appreciate having been involved in implementing that back in the days when I was working for HSE. I kind of, you know, recognise there's been many years of feedback now to say that the categorisation scheme has not always been helpful in actually picking up cases of noise-induced hearing loss. But it has, the categorisation scheme, if I go back to why it was actually implemented and the kind of initial aims of that categorisation scheme, it was never meant to be used as a diagnostic tool or a clinical tool. It really was there to help with that feedback to the employer for those similarly exposed groups, to provide the employer with a simple picture of the hearing health of the workforce, so they could easily see that in this group of workers, I've got so many who are normal hearing, I've got so many who have got poor hearing, so many with rapid hearing. So it was meant to be a tool to assist in feedback and simplification of the outcome of the results of health surveillance. But it has become a bit of a default tool to saying these people are okay, these people we'll keep an eye on. So it's become more of a kind of health management tool, I guess. And obviously a lot of automated audiometers are just kind of giving these results and this data as a kind of automated process. And the changes that the HSE have implemented recently have really been to address some of these concerns, to say, look, we've always said you should be looking at the audiogram. We shouldn't be relying on only the outcome of the categorisation scheme to deal with these people. That, you know, so that the HSE are, you know, trying to address this by those tweaks and amendments they've made recently to the guidance. So, you know, again, I think one of the challenges with noise and around noise health surveillance is because we've been doing it for so long. We've had, you know, guidance for audiometry at work, for noise health surveillance at work, you know, from back, you know, 1975. So we've kind of got into the habit, I guess, in terms of what we do and how we do noise health surveillance. But I think now there's a real sort of question around how fit for purpose it is and how fit for the future. So the changes to the categorisation scheme, you'll see in the second column there. I mean, when I say recent, it was a couple of years ago now that the HSE slightly amended, just to make clear, really, because I think it was always in the guidance that you should look at the audiogram and observe any changes. But they've made it very clear now that actually, in looking at the audiogram and undertaking a visual assessment of the audiogram, you should be recategorising workers. And the implications of that is that actually by looking at the audiogram, a lot of practitioners have now found, oh gosh, we are recategorising people that we had previously by relying kind of blindly on the scheme, said had normal hearing, and now we're saying they've got progressive noise-induced hearing loss. And the implications really for that has been, again, the tightening up that anybody falling into category 3 will be referred to an occupational health physician. And obviously that's had many ramifications in terms of access to doctors and moving people from saying, well, you've been acceptable category 1 for so many years, now all of a sudden you're category 3 and you need a referral. So the UKHCA and the SOM have been working closely for a few years now to try and support practitioners in this area, and we published a position statement, I think it was May last year, which sort of dug around the issues really to say, well, actually through noise health surveillance, we're not diagnosing noise-induced hearing loss. What we're doing is we're looking for indications of the likelihood that the hearing harm has been caused by noise exposure at work. So we've made that clear within the guidance. We provided a bit more detail on how to review the audiogram and what that kind of visual assessment might look like. And we provided a bit more clarification on that kind of referral to a physician in terms of the fact that it might not always have to be a face-to-face referral, that paper referral may suffice in some circumstances. But following on from that, we kind of raise more questions, particularly around, well, how do we review an audiogram? What should we be looking at? And a real kind of call to say, look, just steer us in the right direction, because if we're all doing different things in this area, we're all going to possibly get different results and different outcomes, and we really need a consistent approach to this. So you know, we published, because the HSE had sort of said, by reviewing the audiogram for visual indications, you're looking for, they sort of qualified their comment to say, you're looking for a kind of a notch or a bulge. So a lot of people kind of grasped onto that, say, well, okay, well, what's a notch? What exactly should we be looking for in terms of definitions? So within the guidance that we drafted recently, the supplementary guide to the last year's guide, we presented 4 options for how you might look for a notch. But as I say, we're sort of steered now in the direction of, well, which one's the best? And can you help us? So there's work ongoing now to really provide a bit more detail, because we had also provided the option to use the OSHA criteria for looking for indications of noise-induced hearing loss on the audiogram. So we're now sort of trying to refine our advice, really just to support, as I say, practitioners out there in, well, let's be consistent in how we're interpreting audiograms, and let's be following the same process of that kind of visual assessment, alongside the ongoing requirement to kind of go through the HSE L108 categorisation scheme as well. So what some of these conversations and debate and work has kind of highlighted is that there's still some outstanding questions, and I guess some of the kind of key ones for me are just outlined in this slide. So what's a baseline audiogram? For me, from a regulator, a previous regulator's point of view, I've always understood the baseline audiogram to be the first audiogram undertaken for that employer, or the first one done under that employer. So it's a baseline referral point to look back to say, well, that's how your hearing was when we first tested you with this employer. We can compare any deterioration to that baseline. In clinical practice, you may undertake 3 or 4 baselines, because you might repeat the test because you think the first one's unreliable. So it's the best of the first. So I think we need some clarity around what is a baseline, and what are the duties around a baseline, because you're not going to diagnose, you're not going to identify noise-induced hearing loss from that baseline, because you've got nothing to refer it to in the past. So all you can say is that this person might have noise-induced hearing loss, or they've certainly got a reduction in hearing capacity that we need to look after, but we're not going to refer that individual to a physician for determination of their fitness for work, or for whether they've got noise-induced hearing loss, because this employer hasn't exposed them. So we don't have a duty or a liability to that individual, apart from a kind of duty of care in terms of the risk of exposure, but you haven't harmed them in that case. what is stable noise-induced hearing loss? So if we're shifting a lot of people from category 1 into category 3, which is a kind of having a hearing loss issue, which needs looking at by a physician. When they come back, do they then become stable, or do we have to retest to confirm that they're stable? And when do they kind of move back into that ongoing monitoring phase of the process? I think there's still issues I mentioned before around test conditions and improving those so these tests become more reliable and we don't sort of get the impact of background noise affecting the audiogram, which might trigger concerns about their hearing from looking at the audiogram. And a simple way to sort of, we're trying to look at a kind of flowchart approach to actually how do we go through this process of health surveillance? What kind of interrogation do we have to undertake, and what interpretation are we going to make? So we're trying to sort of visually lay out the process to make it clearer for everybody. So just to kind of summarise the opportunities that we have, because although it all sometimes feels a little overwhelming, really we're all in the business of protecting workers, supporting duty holders in that role, and as I've hopefully alluded to before, in terms of we've got a big problem with hearing health in our population. So what can we do about it? So I think there is a need to improve both uptake and implementation of noise health surveillance, and within that interpretation of the audiogram. I think we should probably fundamentally be questioning whether pure tone audiometry is the best method for noise health surveillance. It's not functional. We don't walk around listening to pure tones to get on in life. We listen to conversation, music, and often in background noise. So would a speech and noise test be more suitable? Otoacoustic emissions testing looks at early changes in hair cell function within the cochlea, so that's the part of the hearing pathway that's first affected by noise. So should we be focusing on looking at hair cell function as an earlier indicator of harm? Should we be picking up other health impacts to demonstrate that maybe at lower noise levels people are suffering from ill health effects? Should we be moving health surveillance to a more simpler tiered approach like we have for HAVs and skin? Are we still doing things differently in noise just because we have for a long time? And the use of specialists, we're all kind of general practitioners, most of us in the field of occupational health, and how do we link and refer for specialist advice through a kind of tiered approach when we feel that's necessary, and what would those kind of triggers look like? So yeah, final slide. I think a review of what we do for noise health surveillance is I feel now fairly inevitable, based on the challenges that we have in trying to fix what we have at the moment. But as I say, I think we're all in the same game of trying to protect people, trying to raise the profile of this topic in particular, and how important it is, and what we can do to make people's lives healthier and happier for longer. So thanks to you all for your attention. I'll just put up my details there in terms of my day job, but also some links to our Hearing Conservation Association on Twitter or X, whatever it's called, and LinkedIn. And I think that's a link to our conference there. So thank you for listening. I'm happy to try and take any questions if I can help at all. Thank you.
Thank you, Claire. That was brilliant. Great summary, particularly a lot of the problems that we face at the moment. I've been looking at the chat box, expecting it to be full of questions, and there is only one at the moment, and people are happy to sort of put some more in there. It's a question, a very specific question. I don't know the answer, but I don't know whether you know. It says, please could you give a specific EN standard, European normal standard, on background noise regarding, I presume that was to do with audiometry.
Yeah,
on audiometry.
You're going to test me now. I can't remember off the top of my head.
Is it in the guidance of
It's in the guidance.
British
It is in the
Society of
guidance.
Audiology guides that they
No,
produce?
it's in L108 as well.
Yes, yes.
Yeah. But I can dig that out and forward that. But yeah, there is it's about the acoustics of the environment for undertaking pure tone audiometry.
Right. Okay. Well, as we're waiting for questions still, can I be cheeky as chair and ask what maybe sort
not
of
too difficult.
no. It's possibly more a sort of additional thing about you made the point at the beginning about the sort of dementia risk and all that sort of stuff, and the effect of losing your hearing. But there's also, I always think, it's forgotten some of the other things around. In other words, the actual sort of disability that people get is not just the fact that their hearing is less, it's even the social side of it, like the crowded room. When you mentioned the speech in noise audiometry, which is a better reflection of that disability, but that people also sort of have a temporal problem because of the system, it's going through the through the cochlea and then the eighth nerve, that they classically miss the punchline of a joke in a crowded room. And it can be, very, very, very debilitating. And the other one is the hyperacusis, which people get, which is when people, like you're in Costa or something, or the cafe, and you're next to the machine that's pelting away with the frother, and it's terrible for people with this hyperacusis. So those other factors are quite important. Right, I've guessed on now, waiting for some questions. They're coming in, so that's good. So when would you advocate ENT referral for noise-induced hearing loss, Claire?
So I've been looking at kind of scoping out what a tiered approach might look like. And I think, obviously we've talked about referral to kind of ENT specialists, but I think there's a role for audiologists. Most of our audiologists work in the field of provision of hearing aids, basically. You don't get many preventative audiologists, but they're the real experts in the field of kind of hearing health. And I've been working with the BSA more recently, and I think there's a real opportunity to refer for kind of those more functional tests, I think, as part of the health surveillance program. So, we use audiometry as a screening tool. So who might have a hearing health problem, yes, we definitely think it's to do with work. Well, like we do with HAVs, do these people need a more kind of functional assessment of, well, what kind of impact does that have? Because that's going to affect our risk management, like you say, if they've got problems hearing communication in work, if they've got problems with hyperacusis, can we develop a tiered approach where we don't do otoacoustic emissions tests for everyone or speech and noise tests for everybody, but those who come through the screening process. So that, as I said, I think we should be moving towards a more tiered approach, similar to HAVs, where we access the right specialists. And I'm not sure ENT would be the right specialist, but I think audiologists possibly could definitely play a bigger role in health surveillance for those.
Yes, I mean, it goes back to the slide, what's a notch and what isn't a notch type thing. And what we've been discussing in the special interest group is this business about the notch can occur in a sort of quite a proportion of the normal population as such, and unexposed, and also in those who are in that situation where they're not they're working, but they're not exposed, and they can get a notch, if you follow me. And that the other thing, of course, is the differential diagnosis aspect of all this, being the other causes of a notch, potential causes of a notch, solvent exposure, antibiotics, the aminoglycoside antibiotics, head injuries. So there is a situation where they're not just for the noise-induced hearing loss, but also those situations when you want to exclude some other pathology, I think is where the ENT referral comes in. Right, there's another question coming in. I think somebody said, "Oh, links with specialists," but in my time in OH, ENT consultants have no interest in hearing loss. They're only interested in treatable pathology, I suppose. Yes. What do you think about that, Claire? I mean, I suppose, you know, from my point of view, yes, I would partly agree with that. There are some, you know, of those who do medico-legal reports who are more interested in the noise-induced hearing loss side of things. But yes, I mean, I take the point.
Yeah, which is why I think audiologists in a preventative role might be, you know, more closely the best specialist to refer to rather than ENT. That's my view.
Yeah. It's another question here. Should you always use a soundproof booth to conduct an audiogram audio test, or would it be suitable a room that's quiet? Would that be
it's very difficult to get the appropriate test conditions in a quiet room, and it doesn't take much to affect you know, some of those frequencies that were tested. So, you know, really, I know now you can get some sound cancelling headsets. So it's like an integrated audiometer within the headset, which can be useful where you can't, you haven't got access to a soundproof room or a booth. So that's another option. But I know there's difficulties with these mobile units as well in terms of doing audiograms in them because they just can't get the conditions, and it's a challenge. You know, we've got a workplace where we're trying to do these tests, and it's not ideal at all. So, which is why I think sometimes maybe we need to think about a different test which can actually be done in an operational workplace. But okay, no, not really.
Question on baseline now. If a new baseline shows signs of noise-induced hearing loss, does this require on-group referral to an OHP?
So I think the recent feedback from HSC, so if it's a baseline as in first test under that employer, then an OHA can make a decision on whether they think it might be noise-induced hearing loss or whether it's a hearing loss that would affect their safety at work. So an amendment to the risk assessment would be required to look after that person's hearing or to make sure they can communicate hear warning signals, etc. So the feedback from HSC is that because it's not a kind of a liability issue, let's call it, it's not being caused by that employer, but any hearing loss that is there, it doesn't require referral to an occupational physician.
Right. What about temporary threshold shift? How many hours noise-free should be arranged before should be allowed before audiogram takes place?
So I think the kind of general consensus is we say like 16 hours noise-free. But again, thinking about the practicality of that and people, you know, I don't know, even listening to podcasts going to bed or you know, listening to music on the way into work, I think it's really difficult to achieve that. I've sort of shown an interest in the fact that I know in some countries that maybe we should be measuring temporary threshold shift as an early indicator of noise exposure. I know that doesn't help with the process we've got in terms of audiometry, but you know, you can imagine trying to say to somebody, you know, look at the temporary threshold shift you've got from not wearing your hearing protection properly or whatever it might be. But yeah, there's a real, ideally 16 hours noise-free is what we usually say.
Yeah, okay. Yeah, I've heard that about temporary threshold shift as well. What would you do if you can't get a result from somebody due to extremely poor hearing and you can't categorize?
Oh, I guess that again becomes a kind of safety issue. And if you've got a background, a kind of previous audiogram to compare to, I mean, obviously that's going to be a real concern. But again, you would be referring them on for further examination by a specialist. I wouldn't be focusing on the categorization scheme in that case. I'd be thinking about, you know, is this individual able to do their job, and what should we be doing to look after them? As I say, the categorization scheme really is only a tool to help feed back to the employer, we still have to apply our kind of clinical response to these kind of situations when they arise. So yeah, I think I'd be referring them on to an audiologist in that circumstance.
Yeah. Okay. Has there been recognition that long-term tinnitus caused by acute COVID, bracket short-term tinnitus, side effect of certain vaccines?
Yeah. I mean, when I say recognition, yeah, I've heard, long COVID causing problems with hearing loss, and with tinnitus. There is some evidence out there. Again, as part of that kind of noise and health questionnaire, you would be trying to get to the bottom of some of these things if you could. Again, it's about looking at the risk in the workplace and then relating the risk in the workplace to the symptoms and the reported outcomes of the health surveillance program, and whether you could link that to work or whether it would be other advice that you'd be giving the individual. But yeah, I've heard about both of those. But there's lots of other things that can cause hearing loss and tinnitus that we need to sort of preclude when we're doing our assessment.
It's certainly, there are papers on sensory neural hearing loss and COVID and the vaccine as well.
Yeah.
Right. Another question. Can you clarify which method should be used to identify an audiometric notch? I think, great question. I think I will follow the Wilson model, but there are so many, I think this causes confusion. Do you want to answer that?
Do I want to stick my name on anyone? Yeah, I mean, we had a meeting, last week, wasn't it? About, whether we could come to a consensus, and it really does become a sort of, let's just decide which might be not the best, so to speak, but maybe the most practical for the situations that we undertake this testing. And I think the steer from the kind of noise-induced hearing loss subgroup, specialist group, was that we probably steer towards the 4K definition, only because we know there are issues around the effects at 6K, which are usually to do with that kind of background noise affecting the outcome. So if we use 6K as part of the notch definition, then those kind of artifacts might start to creep in, and we'll get a lot more referral than we need to. We don't want to focus too much on the notch, because there is, as Ian said, issues about when you will get a notch which isn't a notch, or a notch that doesn't indicate noise-induced hearing loss. But we're kind of left where we are in terms of what we do. But I think the steer at the minute is probably towards the 4K, but not to say that the others are not helpful. It just depends on people's time and expertise in audiometry, I suppose.
Okay, thank you. Can hyperacusis be considered an actual clinical diagnosis, or arguably a perceptual and subjective circumstance? Well, I think it is a subjective thing, because people describe it, but I mean, it is, as far as I'm concerned, it's, there's quite a lot of reports about it. How much of that is related to the audiogram, and how much is related to the person, is hard to say. What do you think, Claire?
Yeah, I think there is. I mean, it relates a little bit to that kind of acoustic shock phenomenon. That there was in Australia and other places, where there was a lot of reports of this kind of hyperacusis effect, and a lot of it was put down to a kind of stress psychological response to the noise, not the noise level. But that kind of diagnosed hyperacusis, as I say, I'm not an audiologist, but I'm sure they would use a combination of kind of specific tests of audiometric response or other response in certain frequencies, alongside your self-report situations. I don't think we could dismiss somebody saying, I find it very difficult. I mean, and again, you'll know from reports, around this kind of noise, really, I struggle with. So it will be related in some way to the frequencies, but I'm sure that there's some way to better diagnose that through an audiological process, but that's beyond me.
Thank you. How to respond to employers who feel the HSC changes have imposed costs on them for what is mainly a societal issue?
Oh, for what is mainly a societal issue, I take the first point, and that's where, you know, really that kind of noise and health questionnaire and doing health surveillance kind of rigorously is important, and understanding your risk. I think employers are falling foul not just to this issue around societal noise, but also to do with claims, because they're relying on hearing protection, which has been proven to not provide the protection it says on the tin, kind of thing. And while they continue to ignore best scientific advice and rely on hearing protection and don't demonstrate how effective their hearing protection is, don't demonstrate that they've trained people in how to use them, don't give people a choice, don't fit test things, there will always be a possibility of saying, well, you caused my hearing loss because you cannot prove otherwise. So, you know, yes, there is a lot more societal leisure listening induced hearing loss, but unless employers start to do better in managing their exposure and their risk profile, they will be subject to challenges around, well, who caused what, because they can't defend what they're doing at the moment, is my blunt view on that situation.
Yeah, okay, all right. There's a few more questions. I know time's getting near the hour now. The next one I'm just taking the ones as they come on the list here. When a result indicates 10 dB difference and a repeat test is required, should this be done straight after or at another appointment? Also, updated advice on wax occlusion and continuation of audio testing.
So, well, yes. So usually, I mean, some of the guidance that we're putting together about recalling people for another test, and where at the moment most of the recommendations are call them back after 6 months if the test doesn't seem reliable, or if there's indications of that kind of 10 dB difference, you recall in 6 months and see if that is stable or if that is a real difference. Nothing's changed on kind of wax occlusion. We should be doing otoscopy as part of health surveillance, and again, if anything's indicating that there are other issues with the auditory pathway which are affecting the results, so is not showing us sensorineural hearing loss, then again, you know, we should be identifying that and referring people for individual health backup rather than you know, just blindly relying on the categorization that's churned out by the audiogram. So nothing's changed around that kind of advice.
Okay, thank you. So due to challenges of the complexity of testing, wouldn't this now be best moved away from OH screening altogether and carried out by qualified audiologists who report any findings to the patient's OH provider?
If there was any, if not many, preventative audiologists, that would be great. As I say, most of them are very focused on provision of hearing aids, which is a lucrative business. So we haven't got enough audiologists interested, qualified to do that. But I think, you know, going forward as professionals, we should be, you know, continuing to do in my opinion, a workplace screen, a suitable workplace screen of whether somebody may or may not be affected by noise at work, and then work out what onward referral would be to further identify the levels of that impact and onward care of the individual.
Okay, well, there's 3 questions left. Do you want to carry on, Claire?
I'm all right if everybody else is all right.
If that's okay with the recording side of things. So the question on speech and noise testing and otoacoustic emissions, which you mentioned as new tests in their implementation, are used to replace. Are they going to be used to replace audiometry or just as a follow-up check for audiometry testing?
I think at the moment, HSE as the regulator and most kind of, I don't know, professional bodies in this area would not want to move away from audiometry as the kind of what they call the gold standard. So I think for the initial, and I always think in terms of good occupational health practice, sometimes we need to start to do other things before regulators and standard setting bodies kind of catch up with us. So I would guess it would be a supplementary test for the initial period before it proved its value, both practically, because I think we have a lot of evidence to say they are good tests, but kind of practically applying them in the occupational health field. So I'll try and keep it brief. Supplementary at the moment, but may replace in the future.
Okay. Last but one, tinnitus is also a recognised symptom of menopause, so sometimes can be difficult to determine if caused by noise exposure or menopause, stroke other underlying cause.
It's your noise and health questionnaire again, isn't it? It's talking to the individual and looking at the risk profile. Are they exposed? But is there anything else going on? So,
yes, yeah. Differential diagnosis. Yeah. Okay, last question. How do audiologists define noise-induced hearing loss?
Well, there's lots of different definitions of noise-induced hearing loss. I guess probably the most kind of robust and clearly defined one is the one around disability benefit, which I think is in the what's called the Black Book, as I knew it. So there are definitions around how to diagnose noise-induced hearing loss from a medico-legal perspective. But that's kind of not what we're doing in the field of occupational health and health surveillance. We're not looking for a medical legal decision. We're looking for indications that this could have been caused by work, so we can feed back to the employers. But I can dig that out and forward that if it's of interest.
Yeah, I mean, and I suppose it's that links into what we discussed at the last SIG about this problem of what's health surveillance picking up early pathophysiological challenge, damages at a higher frequency, whereas all the disability scales tend to be the 2, 3, and 4 kilohertz frequencies, and a sort of decibel loss that's based across those frequencies, which
it's quite a high loss as well for disability benefits. So it's quite a significant deafness basically before people can comply with that, which we want to pick up things a lot earlier.
Okay, thanks, Claire. I think that's the last question. That was great. Thanks very much.
No problem. Nice to speak with you all, and hopefully keep in touch if anybody has any other questions.